We're going to do an endoscopic possible open trigger release. A lot of times we can do these endoscopically so we can minimize the length of the incision and the use of any sutures. Essentially, we have some landmarks here. We know that the A1 pulley is where the problem is for this patient, and it's actually right here over the MP joint. And we know based on research that the length of the A1 pulley is about the same length as the distance from the PIP joint to the MP joint. So these will be our landmarks. I generally make a small little incision here, just a little bit distal to the distal palmar crease, or the distal MP crease, and then a little bit more proximal to the landmark of where the A1 pulley starts. And so we'll be doing that right now, and we'll show you the results shortly. I've actually gotten access here to the A1 pulley, and right here the camera is starting proximal to distal, and you can see the edge of the A1 pulley right about there. And we're going to direct our incision along the A1 pulley all the way distally, and you'll see a little interruption here, and that's about where the A2 pulley starts. We don't want to divide the A2 pulley. We're really just going to be targeting the A1 pulley right here. So we'll show you how that goes once the blade's in there. Before I actually like to make my incision in the pulley, I like to put a probe in there just to make sure that I know exactly where my landmarks are. And you can see the edge of the pulley now is being grabbed by the probe, so I know where my starting point's going to be. And then I'll be switching this out to my curved blade, which will actually divide the pulley as we gradually move from proximal to distal. You can see the pulley being divided. Once again, endoscopically, just directing the course of our incision distally. And there you go, complete release. Now you have the nice tendon underneath. Yeah, please. And you can see the edges of the pulley have now been divided, and there's no more compression of that tendon that's been locking up on this patient and giving her problems with grip strength. So this is just another view of what our entire setup is. There's a cannula here that I've inserted right over the A1 pulley. The blade is inside. I've already divided the pulley, so I pull the blade out, and then ultimately what I'll do is I'll just make sure that one more time that the entire pulley has been divided, and I can see that it has. This is the start of the A2 pulley. I don't want to divide that. So ultimately, we've gotten a good release and happy with the direction in which the procedure went. So we have Miss Littlefield here. We actually did an endoscopic trigger release on her. Generally, this is a very common procedure that I do in my practice, either an open trigger or an endoscopic trigger release. I like to do them endoscopically if I can, so it minimizes the size of the incision and gets our patients back to work and back to their normal activities of daily living a lot quicker. Here I just made two small little incisions, and you'll see that previously in the operating room we had taken some video of the actual procedure itself, but there's just two small little nicks here. In the traditional approach, you would have a longer incision, but using the endoscopic technique, we can actually sneak up underneath the skin and get on top of the pulley, which is a tunnel that's restricting the glide of the tendon. And now you can see she's actually got good range of motion, no residual locking, a little bit of swelling that's limiting full fist flexion. So what we'll actually end up doing for her is have her start doing some massage techniques at home, start to soften up some of the scar tissue. I'll be following her very regularly. We'll see her again in probably about 4 to 5 weeks. But during that time period, she's going to do a lot of work at home to soften up the scar tissue. But the important thing is, Miss Littlefield, how's your pain doing? How are you doing post-operatively?
No pain.
Yeah, doing okay?
Yeah.
All right. Well, we're happy with the results so far. It's going to take a little bit of time. I always tell my patients it's about 6 to 12 weeks of recovery from the actual operation itself, but it's very important that they do stuff at home to get the motion going. And with no stitches there and no long scar, the recovery is a lot faster. All right, we're here with Miss Littlefield. She is about 6 weeks status post an endoscopic trigger release. Now, one of the cool things about this procedure is that I do it endoscopically without having to make a large incision in the palm of the hand. She's had no stitches, and her incisions have healed up very nicely. If you actually look at the palm of her hand right now, she had a small little proximal incision right here and a distal incision, and I was able to do everything by passing a camera underneath the skin and divide the ligament, or actually the pulley that holds the tendon in place, endoscopically. So, Miss Littlefield, how are you doing? How's it feel? We're about 6 weeks out.
Good. Good. No pain, no nothing. I can move it. I can make a fist again, so.
No locking, no pain.
Nothing.
And she actually injured herself at a hotel. There was actually a door that had slammed in on that finger. So she actually had a traumatic trigger finger, and it was locking on her, giving her a lot of pain at that first metacarpal joint of the small finger, or the metacarpal phalangeal joint of the small finger. And I think she's gotten a good result here, and we're about to set her free.
Good.
Any other questions,
No.
complaints, concerns?
Nothing.
Good recovery. She's been doing her therapy, and she's been doing home therapy. We actually don't send patients for therapy following these types of procedures, so we're very excited for her.
Yeah.
Thanks for letting us take care of you.
No worries.
All right. You're welcome.